Hello, Dr. Didafo, can you hear me? I'm just trying to check my audio.
Yeah, I can hear you loud and clear.
I don't know which village person went after my audio yesterday. All right, thanks.
Oh, have I turned myself off again?
No, you haven't. I can hear you still.
Okay. I'll turn my microphone off now.
Okay. Hello, good evening, everybody. I don't know if Dr. Shobode is in the room yet. Dr. Shobode, are you in?
I have been with you since, ma.
Oh, good evening, sir.
Good evening, ma.
You're welcome, sir. I was just going to say that, can I please hand over the meeting, the waiting room to you?
Yeah, please. I've been doing that since for you, ma.
Well, thank you very much, sir.
Yeah.
So I welcome everybody to today, and we'll be talking about rickets and osteogenesis imperfecta. So we're continuing on a set of lectures on metabolic problems. I don't know if anybody has sent in cases, but during Dr. Didapo's talk, I'll check on the email page and see if there are any cases waiting. I did ask for cases to come in via the email, and I'll put that in the chat as well now, just for anybody who wants to. So that's that. Without further ado, I'll start off with the first bit of the talk and just talk about rickets. Very simple talk on rickets. And then I'll hand over to Dr. Didapo to talk about osteogenesis imperfecta. Dr. Didapo.
Good afternoon. I'm still here.
Oh, good. So I think I'll take about half an hour. And I was wondering, do you want us to break for questions or to just go straight to your talk after that?
I think we should take the questions relating to rickets first, and then we'll talk about osteogenesis imperfecta after that.
Okay, so we'll go that route and we'll just see how things go. I'll start off screen sharing now and launch in. We're kind of at 3 minutes past 4. We're live on YouTube as well. So if there are any persons who are viewing from YouTube and want to ask him questions, we'll pick up on the questions from there as well in a bit. So can we all please stay muted if we don't mind? And can everybody see my screen?
Yes, we can see the screen, please. Yes.
Good, thank you. So like I said, this is a short half hour thereabouts or less talk. And I think the orthopedic surgeon's input into the treatment of rickets is very simple and very straightforward. And we'll be focusing more on recognizing that this is what is happening. We have to involve the pediatricians because there's so many different forms of problems that we lump together under rickets that while we all can give vitamin D and calcium, it does go a bit beyond that in terms of the medical management, and we should recognize that. And this will then free us up to do what we really should be doing, which is operating on the angular deformities, taking the decisions as to what should be done, when it should be done, how much should be done, and monitoring these children and making sure that they just stay on their feet and have a good quality of life. So the basics of the metabolism of calcium and vitamin D I would go through. This is a very simplified, dumbed down for me version, as it were. And the important things are to just note that the body tries to maintain the values of calcium at a normal level, and it's a very narrow limit, somewhere between 1.8 and 2.2 millimoles. per liter, and it's regulated very, very strictly because bad things happen when it goes lower than that, and bad things happen when it goes higher than that. Now, we should recognize the importance of protein or albumin binding, to be specific. So if you do get calcium values from a lab, you must be sure that you're looking at the corrected values. And if this is not supplied, there are lots and lots of online calculators that you can just input the values into and then get the corrected calcium values from that and decide whether, based on the reference values you have in your lab, whether this is normal or low. Having said that, generally, like I said, when calcium goes low, the body works towards the influence of parathyroid hormone to increase vitamin D production, which increases absorption from renal tubules and from the GI tract. And it also increases bone resorption, which ends up giving you higher levels. And when the levels go too high, the body reduces this by essentially reversing these mechanisms through the influence of calcitonin. Vitamin D itself, we know that a good portion of it can come through sun exposure. Now, it is not every sun exposure, it has to be ultraviolet B rays. And what we used to tell patients in those days is the early morning sun. Again, this initial vitamin D2 gets converted through sunlight exposure, becomes D3. And through the influence of the liver, this becomes hydroxylated. Eventually, sorry, I can't seem to, oh yes. So this becomes hydroxylated, goes into the kidneys, becomes 1,2,5 hydroxycholecalciferol. Sorry, I omitted writing that bit in the schema. And then this eventually acts on vitamin D receptors, which are found in macrophages, in bone, in different tissues to do its work. What are the sources of vitamin D in terms of diet? Essentially, just having a dairy-based diet is useful. Now, this is a good way for people who want to eat kosher or not eat kosher and so forth. So most people, except those who are lactose intolerant, can take milk or can take eggs or can eat fish or have yogurt. Some people, maybe not so much in Nigeria, would have cheese. And of course, there's also the influence of sunlight. This is important. There are other things that you could mention which may not be acceptable to certain cultures, which is why I've just put an average of what most people can take as that. What is not a source of vitamin D? Interestingly, in Nigeria now, we find that a lot of children eat Indomie noodles or some other form of noodles. And it's probably not the noodles per se, but the fact that the child gets full with this quick fix of a meal, doesn't get to eat all the other things that they should be eating because they're full of this already. They're happy with it, they like it, it's nice and colorful. Mom is happy because it takes 2 minutes to cook. And that's the story of how quite a few of our children are becoming vitamin D deficient. Interestingly, my year in Abuja, I dare say that I saw approximately 1 in 4 children with, vitamin D deficiency of some sort, coming in with angular deformities. And every time I asked them, what does this child like to eat? The highest thing on the list was noodles, which is why I have put it up. Having said that, it has been traditionally believed that we do not have vitamin D related problems in Nigeria and Africa. This is a quote from a paper, which I'll reference later on. And this is because everybody assumes that, we have so much sunlight. But now we know that sun exposure is a lot lower than it used to be. A lot of people live in air-conditioned house, go to school in air-conditioned cars. School is air-conditioned. Nobody gets to play outside anymore because you're afraid of kidnappers and armed robbers and so forth. So at the end of the day, long story short is we're not getting as much vitamin D as we think we are. And the recent COVID pandemic as well has probably also pointed out to us that quite a number of us are deficient, including the kids. We'll talk about a few kinds of rickets, and then we'll summarize what we can be doing for them and call it a day. Like I said, the first thing the orthopedic surgeon needs to do is to recognize the possibility of rickets in a child presenting to you with an angular deformity or with an x-ray that just doesn't quite look right in that sense. Nutritional rickets generally tend to be from some form of deficiency of vitamin D, and a lot of this is due to deficient diets. Prolonged breastfeeding as well is partly causal. And I've just said prolonged. How long is prolonged? I wouldn't try and put a date on it, because again, some of these things become contentious as there is a move now once again towards breastfeeding and towards breastfeeding for longer periods. Again, poor sun exposure, and this can be because you just don't have sunlight where you are. So if, for instance, you're living right up in Ireland where they all just look pale as ghosts sometimes, or if you happen to be, not exposed to the sun because you're in Poda or some other religious sects where they just don't go outdoors for whatever reasons. And again, we know that dark-skinned people, including Blacks and Asians, do tend to have problems with absorption. And so that also qualifies as sun exposure as well. You also have poor absorption from the GI tract, and this would be from people who have celiac disease or hepatic disease. What is the pathology of this form of rickets? Essentially, because of all these problems with vitamin D, calcium doesn't get absorbed, doesn't get to where it should get to, which is deposition in the zone of calcification in the bones. And ultimately, we have a disorder of the physeal plate. It thickens, it's not really forming bone, it's soft. And every time that sort of child puts weight on it through crawling or puts weight on it by walking, the physis just doesn't hold up. The bones bend and they give all the other radiographic and clinical features of rickets that we know. What is this again in terms of anatomy? The problem is a failure of calcification, and this then leads to a disorder of the whole of the physis that we will be speaking about subsequently. On the left is just a mnemonic for remembering the zones of the physis, just for exam purposes. Lab findings, you find that a lot of these children have low vitamin D. Calcium may be normal or low. That's still a bit contentious in terms of, is calcium always normal or is it always low? In terms of what you assay for. And your phosphates as well may be normal, slightly low. ALP is high in all these forms of rickets because you do have increased metabolic bony activity. It's just not useful metabolic activity, so to speak. The levels for ALP as well. Usually you'd find these things supplied by references in the lab, but any child that's having something more than, say, 400, you should wonder about what's going on. And if you bother to ask for parathyroid hormone, which is rarely done, it would be high in a compensatory fashion. The clinical features, essentially, you want to look from the head to the toe if you ever have to examine for exams or even just for practice. Generally, you find the nutritional problems in children who are quite small. Depending on how severe it is, you would find them, with younger presentations with more severity and so to speak. Common things you would see checking from the head, you find that they have frontal busting. Some of this could be from delayed fusion of their sutures as well in the older ones, older than 18 months. And you find that the dentition either just, the teeth just don't come out on time, or they come out and they're looking black or dark brown and they're misshapen. Classically, there's the Hutchinson tooth, which has been described. I honestly haven't seen one, but there are pictures of what this should look like as well, and it's worth knowing for interest. The rickety rosary is not common, and it's a sign that you have pretty severe metabolic problems in that particular child. You could have a pigeon chest occurring. If you looked at the wrists, and this is quite common, particularly in a child who is crawling, because they're bearing the weight on the wrist, you see that influence of the disordered facial arrangement at the wrist, and the wrists are wide. I'll show you what a widened wrist looks like, because it took me a while as well to kind of understand what widening of the wrist means. Now you could have angular deformities, and while various deformities are commoner in children who are just starting to walk, you really could have any pattern of angular deformity. So rickets is a good differential for valgus or varus deformities and so forth. You could have fractures, and some of this might look like non-accidental injuries. So it's useful as well to keep rickets at the back of your mind when you see something that just doesn't fit in terms of fracture pattern relating to mechanism of injury. They could have abnormal spine curvatures, and in the really young ones with severe metabolic abnormalities, you could have irritability or apathy or seizures. Again, that will more likely come to the pediatricians rather than to you, is why I have put it at the very bottom. So first picture at the top is wrist widening, and you just see that the wrist, normally your wrist should go in a straight line this way and then articulate with your hand. But you see a bulge around the wrist region as if it's wider than what the width of the shaft dictates, and also to some extent wider than what the width of the hand itself should dictate. Again, you could see varus deformities or valgus deformities. This child has a Windsor deformity, which is a valgus on one side and a varus on the other side. And examiners like to ask you which one started first, the valgus, and then the varus is compensatory, kind of moving out of the way to allow the valgus to occur. And they're quite bizarre looking gaits that result from this. And this is a picture of a rickety rosary. Like I said, they're not common. To examine for this, you have to take the child's shirt or top off, ask them to lift their hands above their heads. If they're not able to support that properly, you can hold both hands above their heads and give a little gentle pull. And then you see the bulges at the costochondral junctions. They always follow that line and splay out from top to bottom, along the costochondral margins rather than just straight down. So if you trace that sometimes with your hand, even if you can't see it, you can feel it. Now, X-ray features important to know are the widening of the physes, the fraying of the physes, which is due to ingrowths of cells in a fairly disorderly fashion following the disordered vascularization as well. The metaphysis splays and becomes almost like a champagne glass at the bottom of the bones. These features are quite easy to see around the knee joint, because the knee joint is a good weight bearing joint in that regard. Looser zones as well are like lucences, transverse lucences at perpendicular angles to the trabecular in that area, which is seen in the bone. And there's poor corticomedullary differentiation. The canals get quite widened. It's almost like there's just no more cortex. And you can see different angular deformities and different patterns of fractures. Now, the X-ray on the left is showing, again, even here with the soft tissue outline, you can see that this wrist is wider than it should be for the size of the hand that articulates with it. And to some extent for the size of the shaft, the bits that we can see. You can see how the physis here is cupped, and you can see how wide the physial region is. A lot of the wrist bones in the child are not quite ossified yet, so it's tricky to see that. But on this side, you can see a bit of, widening, a little bit of fraying, and so forth. And certainly you can see the cupping. Around the knees as well, we can see this child has bowed lower limbs, and it's bowing of both the femur and the tibia. We can see the fairly obvious genuvarum around there. You can see how the metaphysis is splayed, and it's a little cupped as well. The physes are a bit wide as well, and you can see the fray, which is that irregularity of the physial margins. These are things that would tell you that this child probably has rickets. If we cast our minds back to the x-rays we put up last week, we did have a child who had what looked like features of rickets as well, with multiple fractures in different phases along the fibula and the tibias. So how do we treat them? You need to educate them. You would need to give bits of vitamin D supplementation and calcium as appropriate. Again, this is where the pediatricians come in. And there's really no reason why we shouldn't refer more and more of these patients to them, because we do have pediatricians, and I'm sure they're quite happy to look after the metabolic side of things. Again, because there are consequences to the doses that you need to give when you do really have problems, including renal problems that could occur that require a bit of monitoring of the renal function. And the orthopedic surgeon is not suited by training for these sorts of things. And we manage the fractures conservatively, and we just monitor them. Most times, if it's a true nutritional problem that's caught on time, when the metabolic problems resolve, the child gets better, the deformities improve, and you may not need to do much for them beyond just recognizing, monitoring, and handing them over to the appropriate person. We'll talk about a few other things, and then we'll start winding down slowly. Vitamin D resistant rickets is also the so-called familial hypophosphatemic rickets, and there are different forms of this, which again is where things start getting quite interesting and pretty medical. I've put up the genes affected in the main types. For some odd reason, we also tend to discuss renal tubular acidosis as well under this form of rickets. Now, these are interesting because, again, you may find your calcium being normal, nearly normal. Parathyroid hormone may be normal, vitamin D may or may not be normal, but the phosphate is markedly low in serum, and it's markedly high in urine. And as usual, the ALP is high. The clinical features, you would almost always have a history of something similar having happened in a family member. That family member is usually a sibling. And they do tend to have very severe growth problems. So you see a child who is very stunted, with very bizarre kinds of deformities, with delayed walking, just doesn't look right for age. These are children who you should think that, do they have severe osteogenesis imperfecta, or do they have familial rickets? And the radiographic findings, apart from the fact that the findings are then more florid in terms of affecting a lot more bones, they are pretty much the same as what you find in the nutritional forms. How do we manage them? The management is still fairly contentious and should really just be left to the pediatricians. They do require phosphate replacement in high doses. Now, this is something that runs a fairly high risk of renal failure, and they do require active vitamin D supplementation as well. As far as the orthopedic surgeon is concerned, we wait until it's safe enough to operate on them, and then the decision would be, do you want to do growth modulation for deformities that are not at imminent risk of fracture or are not so disabling that the child can't walk, like a leg at 90 degrees? Or do you have to go ahead and do a deformity correction at the time? And that would be doing a kebab type osteotomy or putting on a frame, preferably a more acute correction, really. As much as possible, you wouldn't want to immobilize these children unnecessarily. And your monitoring for this particular group of kids is essentially until they're skeletally mature. And you essentially just manage their problems as they come along. Renal osteodystrophy as well is something that may or may not come towards an orthopedic surgeon for several reasons, and I'll get into that later on. It's a pattern of bone problems that's common in people who have had renal failure treated. Now, we know that a lot of people are doing renal replacement therapies, specifically renal transplants, and we should expect to start seeing more and more of some of these bony problems that are as a consequence of this. Essentially, the body just fails to push out phosphorus, and this eventually leads to an inability to absorb calcium, because the body has to maintain the calcium phosphate product at all times. So if phosphate goes up, calcium has to go down. Now, the resulting low calcium will lead to a release of parathyroid hormone, even though there's nothing wrong with the parathyroid gland itself. And they have some degrees of bone demineralization, and the phosphate increases, gets worse, and the cycle just goes on and on and on. Now, these people will inevitably have signs of renal failure. So you would find those when you do check, in terms of um, checking for the biochemistry, and phosphates would be inevitably high as well. Again, they may be relatively acidotic. The clinical features are similar to rickets, but in addition to this, they may have peculiar slipped capital femoral epiphysis, or they may have avascular necrosis. I'll go into those in the next bit. This is where I said sometimes the first presentation might be the slipped upper femoral epiphysis to an orthopedic surgeon. So it's worth knowing that when the slip doesn't fit the pattern of what you expect to see, you should think that, is this a child that doesn't have a typical slip, but is slipping because of the metabolic problems such as thyroid dysfunction, or in this case, renal disease. Now, what are the things that we tend to find in these sorts of patients? The Roger-Jesse spine is interesting, and I'll put up a picture of that in a short period of time. Brown tumors as well are large lytic masses, and they can be differential diagnosis for things like giant cell tumors and other lytic bone lesions. And they also tend to have marked subperiosteal bone resorptions in different parts of the limbs. And while they have thick physis, they don't have the classic cupping that you find in people with rickets. Now, this is the Roger-Jesse spine on the left side. It always looks like this, so it's worth knowing just for exam purposes as well. And on the right side, you can see those lytic lesions in the digits on the x-rays put up. Those are brown tumors. Again, it's taking together the metabolic picture that gives you the diagnosis rather than the x-ray appearance of that on its own. Like I said, when you find a slipped upper femoral epiphysis, the ones that occur with this renal failure, you tend to have slips that are occurring in very young patients. So for instance, if you find a slip in a 7-year-old patient, for instance, let's say a 7-year-old girl, to make it even rarer, who is not fat, very slim, not particularly tall, no clear risk factors, maybe doesn't like running or anything, just regular kid. And they're often bilateral. The physes tend to be unusually wide, and this is the radiographic feature that gives it away. Now, how do we manage them? We watch them. Because again, like we said earlier, these are children who are quite young. The child is not 10 or 11 that you can, 13 or 14, where you can comfortably put in a large 6.5 mm screw and think, well, I'm trying to shut down the physes anyway. It doesn't matter that I'm doing that because they're near skeletal maturity. If they get worse, you may have to consider fixation with special partially threaded screws, which cross the physes without closing it and shutting it down permanently, so to speak. AVN as well may occur in this group of patients and is related to steroid use and perhaps even to the renal failure itself. Treatment is symptomatic. We generally don't treat them, I don't want to use the word too aggressively, because that's probably not what I'm trying to convey. But essentially, you have avascular necrosis of the distal femoral condyles in a child who's got, end-stage kidney disease. Age is about 10 years. Your options are pretty limited, and most of what you want to do is related to making them comfortable, making sure that you maintain mobility. If there are, say, bits of bone fragments that are in the joint that are causing it to lock, you can invite the arthroscopy surgeons to help you get those out. But beyond that, there's not much else that one can do, because again, you can't stop the steroids that's causing the problem if it's required. So treatment as well, the medical people again take the lead on this one because they're the ones who are treating the underlying renal problems. And for the orthopedic management, you really just follow up. You treat the angular deformities as they occur if needed. Like I said, if you do have a slip that becomes bothersome, you may then have to, insert, hardware to try to contend with that. And you may have to do a realignment osteotomy only if you can be sure that the bone will actually heal. And this is best done by biopsy. So what's the summary of interference in these patients? We have to recognize these problems. We have to reliably order the basic metabolic tests. And this should be done in conjunction with the people who manage this problem. So it's very easy to say you would order calcium, phosphates, and vitamin D levels and so forth. But it's worth checking with the physician, at least in your center, and having like a kind of package to say, well, if a child shows up with so and so and so, what are the important things they need to manage the metabolic problem? And have a list that then everybody works with so that all patients are investigated in the same way. Vitamin D assessments are still expensive in Nigeria, but they are available. And you'll be surprised at how many of us are vitamin D deficient and we just think, the bone pains and body pains we have early in the morning are due to old age. So it's worth checking these things. Again, it's important to understand the role of working with the pediatricians on this, because while it's easy enough for anybody to prescribe vitamin D, we rarely would be comfortable prescribing it at the doses that are required for people who truly require serious supplementation. And we're certainly not in a position to manage renal failure if it occurs as a consequence of our vitamin D supplementation, or if it occurs as a consequence of the primary metabolic problem, which we may or may not be able to fully comprehend. What do we do for the bones themselves? We need to understand the cause of angular deformities, one, be able to separate what is a normal physiologic type of bowing from a more sinister or abnormal form of bowing, be able to explain these things to the parents quite clearly so that they know why in an environment where people pay out of pocket, why they're spending so much money checking vitamin D levels, checking calcium levels, checking parathyroid hormone if you need to, and why they have to keep coming to the hospital because you have to keep monitoring them, particularly for the ones that have the more familiar forms of problems. Many of these children are children who you literally keep until they're adults, like I said. So that is achieving a level of trust with the family, because you might need to monitor and modify your treatment based on what is happening. You can't always predict what will go on. Now, in terms of correction of the bony problems as well, growth modulation would be your first point of call if you have, say, various deformities or valgus deformities. Now, in situations where this is not sufficient to restore the mechanical axis, or where this is not, or where there are still residual deformities, you may have to do realignment osteotomies. But this is only if you're sure the metabolic problem is under control, which brings you again back to the physician. And I put up this paper because I think it's just an interesting read, really, not very technical. And it does talk about what the arguments for and against what the real problem is in terms of nutritional rickets. Thank you very much.
Thank you, Kemi. Kemi, is Dr. Adapo there?
Yes, he is. He wanted us to take questions.
Yeah.
And
Oga, can you take over, please?
Yes, I don't think there's anything in the chat box yet.
I thought that if anybody had any questions about Dr. Lawani's questions, then we should probably take it now. I suppose if
yes, sir. Maybe you can ask them to unmute themselves, if they have comments or questions. Sir?
Do people generally know how to put their hands up to ask questions?
Yeah, okay, sir. Okay.
Write their questions in the chat box. I noticed
there's a hand up already. Mr. Dr. Chukwuka, his hand is up already.
Okay, I will just invite him to ask his question. You can unmute himself. There seem to be a few people leaving their mics on, so it was causing distraction for other people. Why don't you unmute him?
I've asked him to unmute
Sorry, that's an error, sir. It's an error, please. Hand raised in error.
Okay, you don't have any questions.
Okay.
Okay.
Okay, thank you, Dr. Chukwuka.
Thanks. So, well, like I said, it's a very simple topic if we confine ourselves to the orthopedics and leave the physicians many problems to them.
Well, let me start getting my talk ready. If I haven't seen any questions, there's a question.
There's a question up, sir.
Yes. Dr. Lashibikon wants to know, what about vitamin D dependent rickets?
Okay. Like I said, trying to separate the type of rickets that a child has, I really don't think it is in our purview, because it does go a bit beyond just doing a vitamin D level and doing, calcium and trying to see which is high or which is low. It goes into the purview of doing an ultrasound of the kidneys, checking up on the family history, doing genetic studies, checking the urine as well, and trying to then say what exactly is wrong with this child. Now, what has made the treatment a little simplified from an orthopedic perspective is the fact that most people now will give you vitamin D3 almost as a routine. And there are a few times when people would give, what's the word? Would give, say, vitamin D2 as well. So that's why I didn't go into as much of the metabolic bits that I could have, because I think it's a bit confusing, to be honest. And honestly, for us, it doesn't change what we do. Hello?
Someone sent a message to me here. It said, Dr. Shubodi, kindly help me ask these confusing terms in exams. What is healed ricket, healing ricket, and burnt out ricket? These are questions they ask all the time, and I don't know why he doesn't want to put it up here. Maybe the guy is in the YouTube class. Do we have the link to the YouTube?
No, the trouble is he may be a resident about to take exams and he doesn't really want.
And he's quite confused about it.
Yes. So
can you take the
I will
healed,
try.
healing, and burnt out?
Okay, I will try. So I would say burnt out is when you don't have the metabolic problems, but you have the residual abnormalities that have come from rickets. This is how I understood this as a resident. Like I said, some of these terms, I don't know where you read them per se, but we all learn them from our seniors. And this is how I recall it. So when you have burnt out, you've had rickets treated, metabolically inactive, and then you have, what's the word now? You still have deformities as a result of that. Now, healed was the next one, wasn't it?
Yes.
I don't think technically what the difference would be between healed and burnt out, to be quite candid with you. And I'm not really sure where healing is. Again, these all act as if rickets is one entity, regardless of its cause, which I think is the problem we've had with this. And like I said, we're not the ones treating this. So will you say, healed or healing or burnt out? Is this healed or healing or burnt out nutritional, healed or healing or burnt out familial, which will never heal or burn out because they do have a genetic problem and they require treatment for life? You understand my point? So like I said, if we stick to the orthopedics, the job of rickets becomes very, very simple. And that is, should you put an 8-plate in these patients? Should you watch this one? Should you realign this lower limb? Should you treat this fracture in a cast or not? Should you discharge this patient? I know that this sounds quite simplistic, the way I've put it, but we're not physicians, so I won't get into all that. Otherwise, we'll be discussing hypophosphatasia, we'll be discussing all sorts of things as well as differentials and trying to just wade through them.
Okay, someone wants to know, you have an 8-year-old lady, or girl rather, an 8-year-old girl with rickets, diagnosed with rickets. Sorry, I'm trying to paraphrase what he sent to me. With TFA of 15, I assume the TFA means tibiofemoral angle of 15 degrees. What would you do?
So you said 8-year-old girl has that rickets. As a rule of
diagnosed
thumb,
with rickets and has a TFA. I assume with valgus knee, you said valgus knee, TFA.
I'll assume that is valgus. So I would assume that one, this is the first time you're seeing this particular patient. As a general rule of thumb, you should be wary of intervening on children you have only seen once with an angular deformity. Now, except if, like I said, the deformity is 90 degrees and this child is crippled, cannot walk, you have to do something almost immediately. There's always time for you to, one, get what the metabolic parameters are, discover how much, in terms of treating discover how much in terms of treatments the child has already received, and discover whether it is safe for you to operate. The second thing is, are these problems getting worse or getting better? The best way to find that out is to see that child 3 months down the line and then check again. What is checking? Sorry, I didn't mention that. I suppose I just assumed that. So checking means you want to do the knee angles. Strictly speaking, you're not really doing a tibiofemoral angle clinically, because you're not essentially measuring the angle between the femur and the tibia with your goniometer, because you can't see that. That is a radiologic thing. So you want to take x-rays of the lower limb, starting from hips all the way down to the feet. You want to take these x-rays standing, so that way you can then calculate and see how much of the mechanical alignment is off. You expect that the child who's around the age of, say, 8 years should be correcting towards what is the residual degree of valgus that she would have, which would be somewhere between 5 and 7 degrees. And 15 is a bit off for that kind of person. But even at 15, I would wait, see that child again in 3 months' time. And if in 3 months' time I think things are getting worse, then I can make a plan to put in 8 plates to straighten that out. The reason is this child will grow a girl until she's about 14, 15 years of age. So you have 6 years to correct this knee valgus once it's not extreme, and this is not extreme. So there's no pressure in that sense to grab the child and take the child into theater and go and sink in 8 plates. Because if you do that in bone that is still too soft for that, your screws don't hold, things can fall out. It doesn't necessarily help the child in any way. And if you do that in a child who is already spontaneously getting better, then you've also wasted time and money and exposed the child to unnecessary risk.
Sorry, Kemi, if I can recap. You said
Yes.
if that girl that is 8 years old, you would see her after 3 months. If she remains 15 degrees, what would you do?
I would see her
And
again.
when would you intervene if the deformity remains constant? That's the angle.
So if she remains constant, the important thing is to be able to follow the child up. I would see her again at 3 months mark, see her again at the 6 month mark. Like I said, I have 6 years to correct her alignment.
Okay.
So there's no pressure with needing to do the surgery now. Now, if she remains constant, if you correlate that with the metabolic problem, if you think that in terms of her rickets, she's getting better, you could watch and see, or do we think this is getting better spontaneously? Or do we think this is static, or do we think this is worsening? If it's worsening, definitely worsening, then you do have room to say, yes, put in 8 plates. You can always take them out by the time she's corrected to neutral or slight varus. If, assuming that, of course, by then you've at least started getting on top of the metabolic problems. Now, if you think she's not getting better, or if you think she's static, then you can watch a while. You could watch 3, 6 months, maybe even 9 if things are not worsening and there's no consequence unduly to have from that.
So because Kevin, sorry, I have my reasons for asking these practical questions. They're actually sending these questions to me directly on this Zoom platform. Okay. I'm seeing direct messages to me. So maybe because they are used to me, that's why they are sending that. I have another one waiting for you to answer. But I just need clear answers to these, you know. So if you said that girl that is 8 years old has 6 more years to grow, won't you be worried about that second growth spurt just shortly after menarche? Wouldn't you want to intervene around menarche?
I would. I said,
I'm trying to give you a background.
Okay.
A girl child is supposed to stop growing within 18 months to 2 years after menarche.
Okay.
A girl child will stop growing. That second growth spurt occurs shortly after menarche. And 18 months to 2 years after menarche, they will stop growing. Wouldn't
Okay.
you want to take advantage of that second growth spurt to correct that valgus deformity by doing a hemiepiphysiodesis?
I would, but I wouldn't do that if I'm seeing the child today, is the point I'm
No,
making.
I'm not talking about today. I'm saying that child came at 8 years, you evaluated 3 months later, 6 months later, 1 year, deformity constant. I believe this person had a reason for saying 15 degrees. Deformity is constant. So I'm taking it a notch higher. Deformity is constant.
What would we do? If I
What
waited
would you
6
do
months, I'm
at
sure that, what would I do at 9 months? I would say
No, as in, would you wait for the child to be 9 years, 10 years, 11 years, 12 years?
No,
When
I
would
would
you
wait.
intervene? That's it.
I think personally I would intervene around the 6-month mark after I start seeing the child, provided I'm sure that the metabolic problems are being sorted and at least they're not
Yeah, I mean,
worsening in that regard.
we're assuming it's burnt out now. It's burnt
So
out, it's
I'll
healed.
intervene at 6 months.
6 months after the first time you saw her at 8 years.
Yes.
Okay. Someone else wants to know, and if it was virus, you would do the same, I assume.
I would.
I'm assuming very safely now. If it was virus, you would do the same thing.
I would.
Yes, someone wants to know, good evening, Chief. I assume the person is actually talking to me. Please, how would one evaluate a 5-year-old girl with features of unilateral Blount's disease, in bracket, clinical and radiologic, and blood chemistry of reduced calcium, phosphate, and vitamin D3? I can copy the question and put it in the general.
The general chat box. Okay.
Yeah.
So say if a child comes to you with what looks like unilateral Blount's
I believe you
disease.
can you see the question now? Can you look at it? I just posted it.
Yes. Like I said, if a child comes to you with what looks like unilateral Blount's disease, reduced calcium, reduced phosphate, reduced vitamin D3, one, you will get the pediatricians to see and find out why the calcium is low, why the vitamin D3 is low, why the phosphate is abnormal. Because while people say, you usually don't have double pathologies, in children, you could have a double pathology. It would be a very unlucky child, of course, who would have Blount's and rickets in that sense at the same time. I honestly haven't heard of one, but you never say never. So you think of the fact that there's an underlying metabolic problem that you have to deal with, whatever the cause. And then you treat the Blount's on its own merit. How bad is this Blount's, for instance? People who, when did this various deformity start? Are we sure this is actually Blount's disease or more like a windswept problem? But let's assume that it's actually Blount's. You treat that on its own merit.
Okay.
Yeah.
And
that
Dr.
will be sticking
Ejendi
in
said,
8 plates because of the age. 5 years with Blount's, you must do something. Again, you want to do your x-rays. So standing, limb length alignment views, see what the alignment of the child is like, see what the slope of the physis is like, decide whether the mechanical axis, that's obviously in varus, decide whether the knee joint line is still horizontal or whether that has sloped and whether you need to correct that on its own merit with an intra-articular, epiphysiodesis. Decide whether you have a physeal bar, because 5 years for Blount's is not young anymore. So you manage the Blount's on its own merits, but you must get the input of the pediatricians first of all as to what exactly is going on, just in case it's not Blount's and it's still a metabolic problem, and then you see other features and other things. Another thing I should mention, which again I just alluded to, is you must always check the x-ray of the wrists of children who have rickets, because particularly the younger ones, a lot of those features flare up in the wrists as well, whereas something like Blount's will not flare up in the wrists of the child. It will just be sticking the
if I
proximal
may
tibial
ask you, Kemi,
physis.
why would you be interested in the wrist of an 8-year-old?
And that's what I'm saying. That I said particularly the younger children, because
like children that are still crawling. I know
even
that
in
in
children who are
rickets,
not crawling, even in ones who are like 3, because it's all the physis, more in the weight-bearing ones, then you will see those features. So you would still pick up some features in the wrist of somebody who has rickets, and you would never see changes of any sort in the wrist of somebody who has gout.
Okay. Dr. Izuagba, if you could unmute yourself. I mean, this is the time for you. We need you to talk here, sir. We need your contribution too. Dr. Izuagba, you can't afford to be quiet in the room. Ibrahim Badebo, please, if you can unmute yourself as well before we take osteogenesis imperfecta. We have like 5-10 minutes to talk to you guys. You guys see a lot of all these children, so it's time for you to talk. A lot of people are asking questions. Kemi, if I can ask one more question before those guys come up. If you are seeing this 8-year-old with a varus or a valgus knee of 15 degrees both ways, and the child has, little potential for growth, that's the physis, what we typically call the popcorn physis, what would you do if you are seeing at that 8 years? You've screened metabolically, she's healed or she's burnt out already. What would you do? Yeah, I mean, she has popcorn physis. That's little potential for growth. Obiodu, please, you can unmute yourself as well.
You would still think about things based on how much of a deformity one has. So whatever what's the word now? Mild deformities, 10 degrees, 15 degrees. I would take whatever benefits the 8 plates can give and wait and watch with that, and then plan to do an osteotomy for the child later, based on how long or how much growth they have left. So the osteotomy then would then be at the end of growth, in quotes. Now, if it's the child who has no growth potential left, so somebody coming with residual deformities from rickets, isn't growing, doesn't have, anything that you can use an 8 plate on, then you go ahead and do your osteotomies after the metabolic problems are corrected.
Okay.
And fix them.
Dr. Owola, you're in the room. Please, can we have your thought on this, please?
Hello?
Dr. Owola, could you please unmute yourself, sir? By the way, Dr. Owola is my teacher. Dr. Emeka Izuagba, we need you guys to talk. These are very practical things. I mean, we have a lot of residents in the room, and some of us also want to learn. Dr. Izuagba, you can talk, sir.
Okay, yeah, sorry. I was in a very noisy environment, so I had to move out far away from there. Yeah, interesting discourse so far. Yeah, a wonderful lecture by Kemi. No, I don't know which one you want me to respond to. I think Kemi
those
has done
practical scenarios. We assume that those practical scenarios that we painted, sir.
Okay. The case of an 8-year-old with
I believe the resident typically mentioned 8 years. That 8 years is in between 5 and in between 11. Some people would say that you should attempt to correct, like doing an osteotomy at about 11 before that second growth spot. So why the person deliberately, I'm assuming safely now, that the participant mentioned 8 for a reason. The ricket is burnt out, is healed, and has a deformity, a valgus of 15. I'm also saying if there's the varus of 15, what would you do?
Yeah. Whether there's a varus or a valgus of 15 and 8-year-old that you've diagnosed as rickets and is healed, the most practical thing to do then is to put an 8 plate, okay? You put an 8 plate and correct the deformity, because you can't leave that child to continue going with the valgus knee so that you don't go and distort the knee, the joint and make things worse. The best thing is to put an 8 plate. That child still has a lot of growth potential left. Put an 8 plate, correct the alignment. Once you've corrected the alignment, then you watch the child, follow up the child. Child was always followed up until maturity. There's no point waiting for maturity. Once you corrected the cause, the metabolic derangement, then correct the orthopedic problem, the orthopedic pathology, and that will sort out the problem.
Okay.
And you don't need to do an osteotomy, since the child still has a lot of growth left.
So
you
you would attend to that child at that 8 years. You wouldn't wait for 3 months, 6 months.
Of course, if a child comes to you now, you need to evaluate the child properly. Child is coming first time. You need to follow up the child, check all the metabolic problems, ensure that everything has been sorted out. Vitamin D is normal. X-rays, ensure that the feces are mature enough. They are not sick, because if you put an 8 plate on a sick feces, it's not going to respond. You're going to cause more problems. So if all that is,
you must be sure that the feces still has some growth potential remaining.
Exactly. That they are healed enough, that they are that they are mature enough to be able to respond, because the growth plate you are putting is a tension band plate. They are mature enough to respond to that. So if all that is has been if everything has been is okay metabolically, and then of course the rickets is burnt out, then go ahead and treat the child. Put an 8 plate. That's the simplest thing you can do. You don't need to do an osteotomy at that age for such a little deformity, and that will sort out the problem. But of course, if the child, if you are seeing the child after growth, then of course an osteotomy will be your choice.
Thank you very much. Thank you.
For the other one, a child that has, of course, I've seen rickets and blunts. You see that a lot too, occurring in the same child. Okay.
Yes.
Same thing. Yeah, same thing. Sort out the rickets, and then treat the blunts.
Okay.
Yeah.
Thank you very much.
Hello, somebody, if I may say something.
Yeah, Dr. Wala, yes, sir.
Yeah, I agree completely with Dr. Izuagba about the first patient, 8-year-old with 15 degrees of Vargus or virus, burnt out rickets. So if you see the child first time, you evaluate the child, make a proper diagnosis, know exactly what you are dealing with. If the vitamin D is still low, you can start vitamin D supplementation immediately. See the child again in 3 months, check your vitamin D again, see him again in another 6 months. And if the vitamin D seems to be getting better, then go ahead and do an 8 plate. As you know, the angular deformities, the spectrum of angular, the spectrum of angulation at the knees, by the age of 8 years, you expect that the child would have assumed the adult value. So whatever, so at that point in time, from age of 3 to 4, you expect valgus, which will be maximum at 4. By between 4 and 8 years, the valgus corrects to the adult value of either 5 or 7 degrees, depending on whether the child is a male or a female. By 8 years, the child has achieved the adult angles. So whatever you see at that age of 8 years, I'm sure that's why the person that posed the question exactly at 8. By 8 years, the child has assumed the adult angles. So at that point in time, you can't wait any longer. You just have to do something, because it's not going to get better. If it is at 6 years, you're advised to wait until the child is 8 years. I'm sure that's why the guy put 8 years. So at that point in time, make your diagnosis. Be sure of what you are dealing with. Correct any metabolic derangements that the patient has. Between 3 to 6 months, if you start giving vitamin D, the vitamin D will correct. And then you put an 8 plate, because the child still has a lot of growth left. So that is what I would do. There's no need to wait for a year or 2. It's not going to correct any further.
Okay.
And for the other one of plants and vitamin D, it's very, very common. I've seen quite a lot here in Igbobi. So it's not, because a lot of children are vitamin D deficient. And that is the truth. In fact, right now, any plant I see, I do the vitamin D. And most of them are deficient. So what I do, I start them on vitamin D. And within 6 months, I go in and do whatever I need to do. So it's quite common. Thank you.
Thank you so much, sir. Kemi,
we have a hand up from Dr.
Makelemi.
Yes, and we have a hand up from Dr. Badebo Ibrahim as well.
Yeah, and also I think Professor Adegbenbe is a president of Pediatric Orthopaedic Association of Nigeria. He may want to round up maybe at the end of the day. we should.
Okay.
I think it would be nice if we can hear from him. Makeleme, can you unmute yourself, please? Dr. Vincent is it Makelele or Makelele?
Dr. Vincent for short.
Vincent. Vincent.
Can I
Dr.
make
Vincent,
my contributions while we're waiting for him?
Yes,
Please,
yeah, go ahead.
Yeah, I'm sorry, I was having a second meeting, so I couldn't respond initially. I heard the comments that Dr. Ezuagba made, so from that I could get the question that was asked. I completely agree with Dr. Ezuagba. 8 plate at that time is what I would do. Put an 8 plate. The child has enough time to get it corrected, and with minimal that's like the minimum intervention that you can put in to correct deformity, and at least the data that we use presently for management of children would suggest that by that age the natural angulation of a growing child's knees would have gotten to the adult values. However, it's also important to point out that we actually don't have local data. Even though that's the data we use, that's the expectation that we have, we do not have local data to actually say this is when the children's needs in our environment gets to the adult values or whatever. For all we care, it could be at 6. We should actually be, it may be that at 6 years old is when we should be considering putting such measures in place, or it could be that it's at 10 years of age. So it's important that for all these kinds of problems, even as we use the available data that we have, we should be working on multi-center studies to get our own data and see what we have in our environment and be sure that we're actually practicing with the right data, with the most appropriate data. Thanks.
Thank you very much. I agree with you entirely. And honestly, I think the nuances of difficulties with data, it's worth having a whole meeting to talk about that on its own. Well, Dr. Lash has a hand raised. May I ask you to unmute, sir?
Yeah. All right. Thank you, Kemi, for the beautiful presentation. I agree basically with all the comments that have been made so far concerning the patient. The only point I want to put in is that in a patient like that at 8 years, after doing the biochemical parameters, we also need to arrange and we treat medically. She'll still give some time for follow-up, because 15 degrees is not really so bad. If it's correcting with medical treatment, then 8 plate is not mandatory. Have a slow pace of correction and they choose to do the 8 plate, which is also quite okay. So there are many ways of skinning it, and we must treat. Thank you.
Thank you, sir. Dr. Ethel Ijokumo has a hand raised. Do you mind unmuting yourself, Dr. Ethel? Dr. Ethel? Okay, we'll proceed and maybe take that later.
It's an error.
Oh, no bother. Dr. Jembi says vitamin D resistant rickets is the commonest. And what is the commonest in the environment? Dr. Jembi, may I ask if you've started or if you've finished your, what's the word? Dr. Jembi, may I ask you to unmute? No. Well, I'll just say what I was going to say. I think it boils down to what Dr. Gbadebo has said, that we honestly really don't have data. We've traditionally assumed that we are deficient, that we're not deficient in vitamin D. No, we know because of COVID that perhaps we are. Same way we've also traditionally assumed a lot of different things. So truth is, we do not have a lot of local data that is new and fresh, you know, and a lot of the studies that have been done before, some of them we could redo, some of them we could modify, some of them we could see what the trends are, and there's just a lot of work to be done in whatever direction you look at, as Dr. Badiba has said. I don't know if there are any other comments. Okay, Dr. Okechukwu, I can't see the rest of the name from the chat. Says,
Obiodu.
oh, okay, I can see Okechukwu Oki here, sorry. Dr. Obiodu, he says he thinks 8 plates is better when the child has a short period of 1 to 2 years of growth left. I think the snag with that is it's very difficult to predict how much growth a child actually really has left. So for one thing, you have to do a bone age assessment using an x-ray of the hand and wrist to be able to say just how much time do they have left. Two, you have to have an understanding that this child will not disappear from follow-up, e.g., okay, it wasn't from him. I thought as much. This is from a Dr. Okechukwu Oki. It's not Dr. Biodo. So you have to know how much growth the child has left, do hand and wrist bone age assessment, which the radiologist will help with. You have to be able to be sure that the child will return at that 2-year mark to end of growth. Because what if the father loses his job, you know, the parents die off, anything can happen. So we don't have that luxury of being able to plan to do something at the last minute. And I don't think in Nigeria, I would wait until I have 2 years to the end of growth if I see that the parents at this time are happy to undergo the correction and if we can maintain the correction. Because for instance, the money they want to use for putting in the 8 plates now and removing it may just end up being used to marry a second wife in another 2 years down the line. And that is the end of your correction. So again, we need to have local flavor to some of the things that we do. And rather than just, you know, going with the so-called international dictates, because many of these centers are funded by the government or funded by insurance, unlike us, where we're completely private. So I wouldn't wait. I would treat, allow it to overcorrect to the other side a little bit, take out the 8 plates, and then wait, counseling the parents that if it recurs, then I have to put it back in. So I wonder if we can go to Dr. Adedapo's talk now, if that's all right.
Yeah, thank you very much. Thanks, Dr. Shubode, for moderating that session, and thanks to all our colleagues for participating. I think that was excellent. I particularly wanted to have the rickets talk first because that's far more common. In fact, I've been around long enough and I've seen a bit of rickets, but coming from my colleagues who actually work at the thick end of things, telling me that rickets is even more common than I thought, is a cause for concern as far as I'm concerned. And I think that these are some of the things that we probably should really be spending time, like Dr. Badibo says, talking about and trying to improve on. Before I go to my talk, I'll just quickly answer the question on 8 plate. 8 plate, 1 to 2 years before growth finishes in a girl, that's at the age of 12. You're talking 12, 13. You will get absolutely no correction if you put 8 plate on at 12, 13 in a girl child to correct angular deformity of any significance. You won't get any correction. Number one, as Dr. Lawani says, you don't quite know how much growth is left. Number two, 1 to 2 years before the end of growth, which is about 12, 13 in a girl, and about 14, 15-ish in a boy, there's very little growth left. You've got about a centimeter. You will not correct 15 degrees angular deformity, for example. So if you see an 8-year-old, 9-year-old, 10-year-old child with angular deformity that is amenable, and I use that word, amenable to correction with 8 plate, then you should be putting it in immediately. If money is going to be a problem, personally, I'm talking to the people that have a private practice, I would suggest, and I don't know whether this will be controversial or not, because we're looking after children. And once you touch a child, you're really essentially involved with that child until the end of growth. I would suggest that if the parents have money to pay, take the money for putting and removing the 8 plate. Because like Dr. Kemi says, by the time you are ready to remove the growth plate, if they don't come back, you might create other problems for that child. So I think it's something this is what the Pediatric Society, these are some of the things we do need to discuss and talk about. In terms of the child with the angular deformity of 15 degrees at 8 years old, well, I think we've all said essentially the same thing. By the time you do the blood workup, you find out the patient's vitamin D deficient, you treat that, and you do all the other things you're supposed to do, several months would have gone by, which is a good thing for the child, because in that time that you're waiting, giving vitamin D, you may get some correction if you're lucky. I suspect that you wouldn't get much correction, but it is quite possible that you will. If the child is 8, there is really, really no rush to take the child to the operating theater the next week and do the 8 plate. And this becomes a little bit more important when private practice is concerned. I do a lot of private practice, both here and in the UK, and I think that sometimes, especially for the children's surgeons, we're less motivated by doing surgery on people for financial gain. But it just needs to be mentioned for the residents, because I don't know whether residents go out to town to take these children to town. Please do not rush into operating on children just because you have now learned how to put 8 plate in. You do need to arrange for that child to be followed up properly and for those 8 plates to be removed in the appropriate time, please. So having said that, I will spend probably about 20, 30 minutes going through my talk on osteogenesis imperfecta. I'm going to share my screen. Share. There we go. Osteogenesis imperfecta, it's not common. It's far less common than what we've just talked about, which is really far more common. And in terms of pathology and in terms of public health, the Blount and the vitamin D deficiency is far more important. I think that the high incidence of vitamin D deficiency in our children is probably something that our public health colleagues should be thinking about and looking at. Osteogenesis imperfecta, on the other hand, is a Cinderella spot, quote unquote, compared to the more common problems that we have to deal with. I'll talk about the incidence, the pathology of osteogenesis imperfecta, the various types of osteogenesis imperfecta, the clinical features, management, future trends of treatment in this really horrible, spectacularly horrible condition that that can afflict anyone. The reported incidence is quite variable. People say it's 1 in 15,000 to 1 to 50,000. And I've used those figures to work out that in Nigeria, at any point in time, we probably have perhaps 20,000 children with osteogenesis imperfecta. I have seen some in Lagos, I've seen some in Abuja. I've seen a few in the UK that I manage. And if you do any amount of children's orthopedics, you are going to come across this. Thankfully, they're not going to be very many because their treatment is really, really difficult. And the child's quality of life is quite poor. The pathology, I'm going to keep this simple and straightforward. Basically, collagen is deficient. That constitutes about 90% of osteogenesis imperfecta patients. either the cells don't make enough collagen, or they make enough, but it's not enough of it. So instead of making 100% of the collagen requirements that your body needs, you're making 50%. Or you're making completely rubbish collagen. Collagen is not right. There are faulty genes that cause this. I mean, it is a genetic abnormality, the osteogenesis imperfecta. You know, you have gene deletions. If you remember sickle cell disease, you have a single point deletion, and that single point deletion on a chromosome results in you substituting one protein for the other, and the child is screwed for life. You get sickle cell disease, 1 point mutation. Same thing in osteogenesis imperfecta. The commoner types, the types 1 to 4, they're generally due to collagen deficiency, because the genes that make collagen are not correct. They're mutated, there are base pairs missing, so you're substituting the wrong protein. This is a good way to explain osteogenesis imperfecta. Imagine reinforced concrete. Just think about it. You know, if you say you want to put your gate up in your house, you want to make gate. You know, to make gate, you have to have concrete pillars either side. Now, for the concrete pillar to hold your gate, they have to put steel rods in it. So they put steel rods in it. Then they will put some paco together, some wood. They build a box of wood, put steel rods. That when you're doing a foundation, steel rods, and then depending on how strong you want the foundation is, you put more steel rods. And then once you've done the steel rods, then you pour the concrete inside. Now that is the structure of bone. Now that concrete that you are putting inside, imagine that concrete, that's your collagen. So that's your collagen. And then the cement mix that you have poured inside that container of wood that you've made to make your post, that is your hydroxyapatite. So when the hydroxyapatite now locks into that iron rod, you can remove, once it's dry, you can remove the wood, and you got a solid post to hang your gate on, and your gate will stand. Now for a child with osteogenesis imperfecta, that iron rod, which is your collagen, is deficient. So imagine instead of using iron rod, you use rope. You use 4 strands of rope, you tie it inside, then you pour the concrete and you put the paco inside. You know, you pour your concrete, and then when the concrete dries, you remove it. And it only takes a small child to lean against that rod a little bit, or a kind of pep to hit your goalpost, and it will fall down. It's not strong. That's osteogenesis imperfecta. So the bone is there. It looks like it's okay, but it's not okay, because all the things that are supposed to hold the mineral are defective. So the mineral is not held properly. The whole structure looks okay, but as soon as you load it, it just deforms and it breaks. And this goes on all over the body, everywhere you have bone. It doesn't matter whether it's long bone, short bone, vertebral bone, spine bone, skull bone, everything is screwed. Collagen forms 35% of the total protein in your body. So you can imagine you've got a gene defect and 35% of all the protein in your body is messed up. You're in trouble. Now, not all osteogenesis imperfecta is due to a deficiency in production of quality or quantity of collagen. Some of the rarer types, type 7 and 8, they're due to other proteins that are missing, also involved in collagen metabolism. So it still boils down to collagen at the end of the day. So this is just for exams, because there will be somebody who will say, but there's one that's not due to, it's still collagen. They're just different proteins. But the vast majority are a deficiency in the structural integrity of the produced collagen, or there's not enough of it. It's like using short iron rods for a long goalpost. It will still fall down. And this is a bone specimen for osteogenesis imperfecta. So when you take a specimen of bone from a child for osteogenesis imperfecta, say you take a bone specimen from a 2-year-old, it looks identical histologically to something you would take from an 80-year-old woman with severe osteoporosis. They look the same. When I was in medical school and when I was a younger resident, and right up until the time I actually did my fellowship, there was only 4 types of osteogenesis imperfecta, types 1 to 4. And as an orthopedic person, you kind of knew them at the back of your hands. But these days, there's a lot more. As soon as you find one, this is from genetics. I don't know whether we have a lab that will be able to do some of this genetic work for us. But then this is work that is outstanding for us to do, because we don't know what variants of osteogenesis imperfecta we have here. And ideally, every child who has osteogenesis imperfecta, particularly that you have to do surgery on, we should be sending bone samples off to the lab to do some of the gene testing to actually identify which particular type of osteogenesis imperfecta and what are the prevalent types in our environment. It will still be the COL1A1 gene and COL1A2 gene, but like I said, about 10% of OI cases are due to all these other variants. This was the silence classification with the more common variant of osteogenesis imperfecta, type 1 to 4. Type 1 is a mild one, autosomal dominant. But they say autosomal dominant, but a large proportion of these patients have actually mutations, so they didn't get it from their mom or dad. It was de novo. And even the ones that got it from their mom or dad, it's not quite autosomal dominant. It just means, it's just that if, say, for example, you've got 2 copies of COL1A gene, you got 1 copy from your mom, 1 copy from your dad, and the copy you got from your father is defective, it means you're probably going to be making 50% of the collagen that you're supposed to make. If you're only making 50% of normal collagen, well, your bone quality, your skin quality, your sclera quality will be poor. That's why it looks like it's an autosomal dominant. And we've worked all that out now that it's not quite dominant. It's just that collagen is so pervasive. If you lose one of the genes from either parent, you're still a bit screwed, really. Type 2, it's generally a new mutation. You can't inherit type 2 because type 2 kills you before you reach your first birthday. In type 2 osteogenesis imperfecta, most of the children, when you do ultrasound, pregnancy ultrasound, they're already starting to have fractures in the womb. The bones are that fragile, you know. So you see an ultrasound scan at 20 weeks and the baby's already got a broken femur. That's really bad news. And in type 2 OI, they're like that. They come out of the womb, whether you deliver them by C-section or paraplegia, it doesn't matter. They will have several rib fractures by the time they're born, 1 or 2 broken bones, and it's not the obstetrician's fault. Sometimes if people don't know, they will blame the obstetrician, then they will do a commission of inquiry, and then they will give the guy suspension. And by the time you find out it's OI, the guy is stressed, he might have hung himself. It happened. So OI, one of the differential diagnoses is child abuse. We need to be careful. Type 3, this is quite severe disease as well. Type 3 are the ones where you get your osteogenesis imperfecta. You're born, you look normal. And by the time you're getting to 1 year old, you start crawling. And you're crawling, and you try and grab a packet of script and your arm breaks. And then somebody thinks that the Omodo did it. No, the Omodo didn't do it. They've started to break. Once they start to walk, the limbs start to deform. Tibia starts to bend, femur starts to bend. These type of diseases usually quite severe. And it's if you look after them well and you rod the femurs and things, they can be kept alive and kept reasonably comfortable for a significant period of time. But they're the ones that we generally see. Excuse me 1 second. Type 4, mild to moderate severity. Some have growth impairment. Type 1 and type 4 look similar. The way I used to remember it is type 1 is the mild to moderate one. Type 4 is also mild to moderate, but the one generally gets a blue sclera. And the type 4, they don't have blue sclera. But some type 4s can be severe. But in general, type 4s are usually moderate like the type 1s. And when you think that you have learned this, then you get this, where you have now several different types. This is because we started doing gene testing. And then we're finding lots of different, so you think that, okay, this is osteogenesis imperfecta, it must be due to COL1A gene and COL12A2 gene. And you suddenly figure out that actually you have so many other different problems that so many other gene pathology that cause osteogenesis imperfecta. So you can see the different types. You got 5, you got 6, you got 7, you got 8, you got 9. In fact, from my reading, it's now up to 15. But the only ones that are really that you see more commonly are generally the type 1s and the type 2s. The type 2, they will die. They have a perinatal death. The type 1 and type 3 and 4, we will see commonly in our clinics. Give me 2 seconds.
While we're waiting for him to get back, I suppose now that we have up to 15, and some of us still only manage to remember types 1 to 4, what is the hope? The other interesting thing is just to wonder if we have any ways forward in terms of gene assessments in our environment, because we do need.
I'm back.
Welcome back.
So this is what it looks like when you have a type 2 in a fetus. There are fractures in all the lumbar bones, multiple fractures. This is how the child is born. The baby is born with pretty much everything broken. It's really, and it doesn't mean babies don't have pain. So you can imagine somebody's broken all the bones in your body and you're so sore. It's really bad. It's not great at all. Now, clinical features. The bone fractures easily. Okay, this is how you know this is an OI. The injury that caused the fracture of the child's femur is extremely trivial. If a child presents to your clinic and the femur broke and they can't quite explain how it broke, a 2-year-old, just walking, 3-year-old, and you've managed to rule out child abuse, then what you need to do is do x-rays of the rest of the skeleton, particularly the long bones, and see whether you have bowing and deformities and all that of those bones. Because if it's managing to break that femur that easily, if you take an x-ray of the other femur, of the tibia, you might start to see that you're starting to get deformities in there, particularly if it's a type 3. If it's the 1 or the 4, you may not see anything. They can get scoliosis. They will get that much later as they grow. They have loose joints and poor muscle tone. This is because, again, they've got really crappy collagen. And collagen is responsible for a lot of what is in your skin. So if your skin collagen is really poor quality, then the skin just stretches, the joints are lax. The blue sclera, that blue sclera is actually because the sclera is thin. So the choroid under the sclera is a bit more visible, which is why it looks blue. I used to think you didn't get blue sclera in Black people, but Black people with osteogenesis imperfecta do get the blue sclera as well, because the pathology is exactly the same. Half of people with osteogenesis imperfecta will be deaf by the time they're adults. And the reason they're deaf is because the bones that are being formed around the eardrums are also poor quality, and they narrow the nerves that carry, the sensory nerves that carry hearing. Neurologic abnormalities you can commonly find. This is related to the skeletal abnormality and skeletal deformity, particularly in the spine. And there's been reports of children with osteogenesis imperfecta having recurrent abdominal pain and chronic constipation. That's probably because of the painkillers they get. The diagnosis is clinical. You can confirm the diagnosis by gene testing. I suppose you could send the bone sample to the lab to have histology done, but histology is not really confirmatory. It just tells you the bone quality is poor and it looks like an osteopenic bone. That adds to it, but really the most definitive way to make a diagnosis is gene testing. Check the genes, and that is essentially diagnostic. But there's a small caveat. If it's one of those new variants that haven't been characterized, then you may miss it altogether yet again. they also have dental problems. So a child that you see in your clinic who has osteogenesis imperfecta needs to see the orthopedic surgeon, the pediatrician, and the dentist. Those are the 4 people that that child needs to keep seeing, probably for the rest of their lives. Treatment. The most important treatment for osteogenesis imperfecta is fracture prevention whenever possible, and prompt, appropriate fracture management if it does happen. Physiotherapy, keeping the joints mobile, keeping the muscle strength as good as it can be, is also helpful. Some of them, if the spine is bad, they may well need some work with the spine surgeons as well. And the use of bisphosphonates, I will talk about in a bit. So stop them breaking their legs whenever possible. So once you know a child has osteogenesis imperfecta, they can play. But a child with OI, it's really not a brilliant idea for them to play football. Because if somebody gives them a kick while they are trying to score a goal, that leg will break. It's just that simple. They do break, and they will break with minimum force. So there are certain things they will not be able to do, and that's just a pity. There are other exercises and other physical activities they will be able to participate in that will be probably less dangerous for them. You will not find anything that has zero danger to them. They are always in danger of breaking their bones from very trivial things. And then it's fracture management. Simple undisplaced fracture, particularly in the upper extremities, are often managed in a cast. But I would suggest if a child with osteogenesis imperfecta breaks their radius or ulna, it's probably best if you put flexible rods in. Get as big a flexible rod as you can in that child, and I would suggest you don't remove it because it will break again. When the child gets old, leave it a little bit proud. When the child gets older, and if they're still fracturing, you can swap the rods. In children with osteogenesis imperfecta, we don't remove metal work. And please do not use plates in OI children, because as soon as that fracture is healed, they will break on top of the plate or at the bottom of the plate. If you can't put a rod in, leave the child alone and find somebody who can help you put a rod in, or call a friend, and both of you can put a rod in whichever bone is broken. This is an example of a child. These are all patients that I've treated myself. Usually the x-rays I show are x-rays of patients that I've treated. I've had the privilege of looking after. So when you see a child with this fracture with osteogenesis imperfecta, of course you can put them on gallows traction. This is a 3-year-old. They can have gallows traction and they will heal in your gallows and they will come back in 6 months and that femur will break again. Because in your gallows traction, you're never really going to get it quite straight. It will be a little bit bent. The mechanical axis of the bone will be off and it will break. So these are the nuances about these children. Everything is different. So you get a child like this, you know you have to rod that femur. It's already starting to break. If it's breaking at 3 years old, 4 years old, it will keep breaking. So you put it in a cast, it'll break again. You put it in a cast, it'll break again. The child then doesn't walk for 2, 3, 4 years. It's an absolute disaster. All these bones need to be rodded. This is what this child had. This is, we call this a Bailey de Bois rods. They're growing rods. These are growing rods. Whenever possible, you need to put rods in that you don't have to keep changing and changing and changing. You know, this is the female part of the rod. This is the male part. So this bit slides into this bit. So as the child grows, that epiphysis pushes against the rod and it just extends this way and that way. And this child, you may not need to change this rod now for probably the next 6, 7 years until it's about 10, when that would have grown completely out of that. That stops there. So it's a lot of growth for this rod to undertake. And really, this is how to treat these children, so you can keep them out of hospital. In a lot of these children, you may have to rod femur tibia on both sides for the child, so that the child can have a good childhood. With this rod in this child, he won't break this bone again until they get to secondary school, and you may have to put another rod in. And that's a mega advance for this child. They can go to school, they don't have to keep coming to hospital. They can still break their wrist, but you put that in a cast and they're usually fine. But in general, lower extremities, you have to rod them. That's how that looks. And that's the other view. These rods will go through the growth plate, often, but it doesn't actually stop the leg from growing. What you don't do with these things is you keep drilling through the growth plate several times. You have one shot, and you put a smooth, and they're smooth rods. And interestingly, I mean, we talk about growth plate damage, growth plate injuries. Growth plate can be resilient. You just need to know what you can do with it and what you can't. These are central rods. Once you are right in the middle of the growth plate, it's not a problem. This leg will continue to grow. There's just a schematic diagram of how you put some of these rods in. There's those rods that I showed you, that Bailey the Boer rod, I don't believe I can get it in the market now. I might be able to get it in some of the Far Eastern countries, but I don't use that in the UK now. In the UK now, I use the FD rods, the Faisal rods. They're easier to use. So those rods, what you do is the male rod, you put that in first. You first of all drill, you drill with your various long drill bits. You start from 2.5. Sometimes I start with a 2 millimeter K wire. You know, this bone has not broken yet. It's lucky. Sometimes if it's broken, life is difficult. Sometimes if they've had pamidronate, life is extremely difficult. It's probably going to be the only operation that will ever make you cry in your life. A child who's had pamidronate and needs rodding for osteogenesis imperfecta, beware, you are going to cry. Everything you touch will break. Prepare for it. Do an osteotomy before it breaks, because when it breaks, there's nowhere to put anything. Okay, so you may have to cut the bone in several places to make it straight. It's called the kebab procedure. So you drill each piece separately. Make sure the muscle is still connected. If you disconnect all the muscle and periosteum from the bone, it's a sequestrum. So they can be really difficult. They're not terribly forgiving. So you keep drilling and drilling and drilling with sequential sizes of drill bits until you drill it to the size you want. Some of these rods are 5, 6, 7 millimeters. So the female may be about 7 millimeters. The male will be like 5 millimeters or so. So you drill enough for it to take the female. Then you put the male rod in and screw it into the physis. Then you cut the female rod to the appropriate length. You'll have to cut the male rod as well. They come quite long, so they fit all sorts. You determine how much of it you want to overlap, and then you put the female in. So you can see the end is in the growth plate. Sometimes you use a K-wire. There's a hole there in the male rod to hold it in the distal epiphysis, and you can use a K-wire as a locking bolt, as it were. You know, this is tibia. And then you put the male rod onto it. And as the child grows, that's in the epiphysis, that's in the epiphysis. As the child grows, this male rod and this female rod slide on each other, and the child continues to grow. So once you've done this and you've done this properly, that's it. This child is good for about 7 years. They don't need anything from you. And because you've already had a rod, and when they come back, say they're 11 and they're still fracturing, you remove this and you just put another one in, a bigger one, bigger size, and allow it to slide a bit more. By the time they reach 15, 16, adulthood, they generally don't break anymore. But this is not patients that you do removal of metal work for. Once you put this in, the child is good to go. This is a real blessing for these children. Otherwise, they're in hospital every 6 months, they've broken something again. It's really traumatic for them. A lot of them that can't have this have a traumatic childhood, and they don't make it through childhood, they will die. This is an example of a Faisal Duval rod. This was done here in Abuja, I think it was 18 months ago or so. That's the female rod, that's the male rod. I'm using it to treat a different condition here. This is not osteogenesis imperfecta. This is congenital pseudoarthrosis of the tibia. There's very little tibia left, you know. And so you put the female rod in, the male rod in, that's the tip of the thread. And then I put the female rod in. This child running around playing and going absolutely crazy. This is now healed completely. I saw him 3 weeks ago, and it was just a delight to see that had healed. So this child can keep this until it's about 6, 7, maybe even 8 years old. This was done when he was 2.5. And by the time he's 8, 9 years old, I may have to do something else, change the rods, whatever. So it's just a lease of life for these patients if they can have a growing rod. Do I have a growing rod here? Of course not. I essentially told the parents about growing rods and gave them the name of the company and sent the invoice to them. They paid for it. The company was kind enough to allow me to bring the rods with the instruments, and the child's treated. Child's pretty much getting on with his life now. We really need to make this available to our own people here. The only reason we can do it over there is because they don't have to pay for healthcare. This rod is £4,000. This FD rod. You're not going to get change out of that. Even the £4,000 is because they're feeling sorry for you. In places where they actually value their people, they will make sure children get this treatment free of charge. We should be pushing for that as the NOA personally. That's my own personal feeling. This is a child that I did last week with osteogenesis imperfecta. That's what the tibia looks like. The tibia has an angle of about 60 degrees. That's the femur. The femur has a 60-degree angle on top. The leg length discrepancy, I didn't bother to measure it. Pointless. She can't walk. She didn't walk. She stopped walking. The father brought her from out of state. I think he only had his bus fare with him. So he actually didn't have any money to treat this child. But we had rodded our femurs before. We didn't rod the tibia because it was treated, because A, the tibias were straight. They weren't broken or bent at the time. And B, it was treated under our foundation, GAS Foundation. We do treat these disabled children. We try and find money, funding for them and treat them free of charge. So we treated both femurs. I mean, I wasn't going to rod 4 long bones. The plan was that when I saw her later, if the bones were bending, I would rod it before it broke. But obviously, it's bent and now it's just, the child couldn't walk anymore. Following the first surgery that we did with her deformed femurs, in 6 weeks, she was running around like a headless chicken. But of course, the conditions caught up with her. The tibias have deformed. This is so badly deformed. I made her stand, but her father was carrying her. She couldn't really walk on this anymore because that tibia was broken. If you notice carefully, that tibia is also bending ever so slightly. So I got a bad femur, bad tibia, and the tibia is slightly bending and it's not quite bent yet, but I know that this is going to go. And so how much money do you want? Even very rich people will find this really, really, really expensive to keep treating. Never mind people that don't have money. We have to find some way of helping these kind of children. This is our tibia. This is the right tibia. This is the left one. You can see the left one is going to go. That's why this is a good time to do the rodding. The surgery will be quite straightforward, will be quite easy. These children get up and start walking by 3-4 weeks, they're fine. By the time they get into this stage, life is impossible or difficult. I don't know whether I'll get away with 1 or 2 or 3 osteotomies. You don't know. So you plan to do what you need to do when you get there. And you basically don't plan anything else for that day because you may be there for hours and hours and you may be lucky. This was the rod we put in the last time we saw about 2 years ago or so. Femurs healed, it's doing really well. This one, well, it broke again. So we have to redo this one and then the tibia under it. So what's the approach? Well, you make an incision in the front of the knee like you're doing an IM rod normally. Then you use your 2.5 millimeter drill bit. You need CM because sometimes the canals are sclerotic and you think you're in the medullary canal and you're not. And there are areas of differential hardness and softness in the bone. So you think, oh, this feels soft. It feels like, it's all by feel. But then you feel you're in the canal, you do your check x-ray, you're way out. You're not in the canal. So you do need the CM to make sure you're actually in the middle of the bone whilst you're drilling. So you 2.5 millimeter drill bit, 3.5 millimeter drill bit, and then 4.5 millimeter drill bit. You keep going up and up and up like that. Time you get to where that fracture site was, there's no canal. That's completely sclerotic, no canal, and you can't keep cutting it away. So you'll have to drill your way into sensible medullary canal to get that done. And we managed to do that, and I don't have any FD rods here. I don't have any Faisal Duval rods. I don't have Bailey Dubois rods or Sheffield rods. Sheffield rods look like Bailey Dubois rods. They used to make that in Sheffield, but I don't think they make them anymore. They use FD rods now. And so we were able to get 4.8 millimeter rush rods in. And that's the tibia after we finished. That's the femur after we finished. If you come back in 6, 7, 8 weeks time, that would be healed. One point to make is if you are doing this in a child that has had palmidronate, you will have a lot more of a difficult time with the surgery. The bones are denser, much more sclerotic, and much more difficult to work with. But you still have to get the job done because you have to line up the bone, you have to rod it, and you have to get the child up and walking again. Otherwise, they have no quality of life because they're intellectually, cerebrally, they're completely normal. It's just their bones that are a problem. I've left this long on purpose because I'm hoping that when I have to go back and do that other tibia in a year's time, then I'll knock this rod and the other rod in a little bit. This is my own idea of growing rods because I haven't got any. So as the child grows, I'm hoping that I can use that and be knocking it down every couple of years to maintain because if you allow this child to not have a rod, everything will break again and she won't walk. And that's the tibia following surgery. Biphosphonate treatment. When I was training, biphosphonate had just come out for osteogenesis imperfecta. And we thought it was going to be the holy grail and we were going to treat all these OI kids and they were all going to be absolutely perfect and normal. And orthopedic surgery will have to go and sell nuts or open a coffee shop or something, pediatric orthopedic surgeons, because there'll be no work left for them. Hasn't quite worked out like that. It does help children who are severe, like this child who just keeps breaking and breaking and breaking. But it comes at a bit of a cost. The IV palmidronates are far more effective than the oral preparations. You have to give it in hospital, and it has to be supervised by a pediatrician. I wouldn't be giving it myself, not a pediatrician. It does make them break less often, but if they do break, they don't unite nearly as quickly. And if you do rod them, you do get a much higher chance of non-union. That's the fact. That's a fact. And any surgeon who's done any number of this will tell you that that has been the experience. So this is the most recent Cochrane database systematic review on this subject. And I just removed a paragraph from the conclusion. It says the studies included here do not show biphosphonates conclusively improve clinical status, improve pain, improve growth and functional mobility in people with osteogenesis imperfecta. With severe cases, it does help you a little bit. With type 1s and type 4s, the jury's out. We don't know. We don't think it helps that much. Type 3s who are breaking all the time, we know it helps, but there's a cost. Thank you very much.
Thank you very much. Thank you very much for your lecture. I wonder if there are comments and questions. We'll wait for those. While you were briefly away, I was saying, just to fill up the time and kind of thinking aloud and wondering, what people have found in terms of needing to do genetic assessments in Nigeria generally.
Now that's a question for the floor, really, because I don't know if there's the facilities available. If it is, I'd love to know so I can send some of the children.
I know that the Pathcare Labs did offer for us to do that. If you remember this boy with radial aplasia, the one we looked after.
Yeah.
The first one. And, they were happy to do the gene test, but they wanted me to tell them which genes I was looking for, which I couldn't tell them. And we couldn't even afford it either way. So I'm just wondering if there are any university-based, persons who are doing these things, even if it's on research basis or whatever, that we can collaborate with. Like you said, that's a question for the floor.
Yes, it's really, I think that's a question that we should take back to the Pediatric Society, because these are some of the things we should really be working on how to access. I think that the way forward with this is we've got to apply for grants that allow us to test these children, because they're not going to be able to afford it. I mean, for you to get this sort of genetic testing that you need to make this diagnosis or characterize the particular type, you're talking 100, 200,000 naira. I mean, most of these people barely have any. This particular patient didn't have any money for this treatment, none. So they didn't pay for this treatment. And those are the sorts of issues we get. I'm sure there are people who've seen osteogenesis imperfecta in their various hospitals. I don't know how they've managed the challenge of treating these children, and I would love to know. And if they want to send them to us at Cedar Crest in Abuja, we'll be quite happy to take over these children and look after it with them or for them. So that's an open invitation. I mean, if you have children with this condition, either you bring the child yourself and you come and learn how to deal with some of this really severe pathology, or you just send the child to us and we'll look after the child. It's not a problem.
Particularly if they don't have money.
Somebody's asking a question. It says that
Yes.
there's a high risk of non-union in treatment of this condition, considering the need for multiple osteotomies. Do you use bone graft in treatment? Where do you source them from? The quick answer to that is no. They will all, those x-rays you're seeing, all those osteotomies will join up between 6 to 8 weeks. If I do an x-ray at 12 weeks, you won't see any gap, be joined up. If you do an x-ray at a year, you'll see absolutely nothing. You will just see the rods. We don't use any. Remember that when I do the osteotomies, I leave the periosteum completely intact all round. You cut into the periosteum, you peel it off, you leave it intact. If you leave periosteum intact in a child, everything heals. You get away with all sorts. So that's the caveat that I gave about the pamidronate. If that child had been on pamidronate, then the risk of non-union is there. I keep my osteotomies minimal, but sometimes you may have to do 2 or 3. This one I've only done 1. That's nothing at all. Sometimes in some of these conditions, I may have to do 2, 3, 4 osteotomies even to be able to get the result that I want. Dr. Izuagba's hand is up.
Yes, Dr. Izuagba, please, can you kindly unmute yourself, sir? Well, while we're waiting for him, I was just going to add that the pathology of osteogenesis imperfecta is that of increased bone fragility, but they do not have slow healing. So they heal at a normal rate, like you said, except the ones who have had bisphosphonates, and that is still emerging. And similar to the sort of bisphosphonate-related fractures we see in adults, they do have those atypical patterns with cortical thickness, usually a transverse fracture pattern, and then they just break. Dr. Swagba says he can't unmute.
Okay, hello.
Interesting, sir. You're muted.
Yeah.
Hello? Please go ahead. Please go ahead, sir.
Yeah. Thank you very much. Thank you, Dr. Delakbo, for that wonderful lecture. We do see a lot of.
Does he have a problem with his volume, or is from me?
Well, it's from him, but we are managing to hear you, sir. Please go ahead. We'll listen carefully.
Okay, yeah. We do see a lot of OI patients, really. Funny enough, in our facility. Getting the FD rod is a challenge. I've been able to contact some of the makers in Canada, and I'm trying to work out something. But in the interim, what I do is I use rush rods, and they've actually helped a lot. The rush rods, at least, I've been able to use for the few patients who still can afford it. Even with the rush rods as cheap as it is, a lot still can't afford. So
what is the, Dr. Izuagba, how much in general does it cost them for this surgery?
For the surgery, for like in the hospital, per limb, using a rush rod, it costs them about 300 to 400,000.
And by the time you put 4 rods in 4 limbs,
yeah.
that's 1 million. They can't afford.
So they can't afford. So most of the time, just manage to do like 2 limbs, using one operation time.
Have you considered using just stout K wires instead of rush rods?
Yeah, stout K wires, yeah, but
because you can use a 3.5 K wire instead of a rush rod.
May I chip in there to say the cost of the surgery is not the cost of the rush rods. It's
not
all inclusive.
It's not.
So it doesn't matter what implant he uses.
Yeah,
Well,
it's
we
not
need
the
to
rush shot that jacks up the price.
have a discussion amongst ourselves. Probably not here, not now. This is what your pediatric
Yes.
society is for. We have to find a way of treating these children. I think it is disgraceful that we have children like this, and we can't treat because the hospital is charging them 300 per limb. We just have to find a way of doing something about it. What are all our NGOs doing? What are people raising money for? Why are we buying Jeep when we can't treat disabled children like this? It's just barbaric, really, in my own opinion. Somebody's asking another question.
It's,
Where the telescoping nails are not available, what should be the precautions when using conventional nails? Now, from what we've been saying, you're not going to be able, get very small, very thin bones. You're not going to be able to use conventional nails. When they're small children, you can use brush rods, you can use, I've used very stout K wires here in Abuja, 3.5 K wires, 4mm K wires, that kind of thing. Even 2.5 is the child's really small. I have another child. I have a child in Lagos that we started treating when he was 8, 9, and we used for him, for his tibia and femur, we used humeral nails to nail him because they were 7 and 8mm. So we were able to get away with humeral nails. So for these children, you have to think outside the box. You cannot use normal femur nails, tibial nails for them. You've just got to think about what works. It's whatever works, whatever rod you can find that fits and does the job is what you'll have to use. He's also asked the question on the social aspect, is it safe for these patients to marry? Why not?
May I address that?
Like everybody else. Yeah, answer the question, Dr. Lawani.
Okay. I would say that they tend to continue breaking until they're skeletally mature. So once you're not planning to marry this child when she's 11 years or 12, which is a discussion for another forum, there's no reason for them not to do whatever they like with their lives, because once they hit skeletal maturity, it's like magic. The bones really just stop breaking, which again makes it imperative for us to treat them appropriately because they're neurologically normal children, normal intelligence quotients, normal potential for everything in life, except that they're going to break their bones until they hit around 15, 16 years of age. And then they're normal, even in that regard. I wonder if that's satisfactory.
The question also is that some of these children really, really end up being really small, short-statured, and if you've missed that much education and that much play, well, you haven't socialized much, so it's going to be a bit difficult to find a mate. There is always that. And then if they have spinal pathology and have to have a spine surgery, there's that as well. And I think some of the other reason behind the question may well be the genetics. So if they have osteogenesis imperfecta, can they pass it on to their children?
Yes.
The answer is possibly. This is where you need a geneticist. So that question, I can't answer it in terms of the genetics until you find out which type of osteogenesis imperfecta they have, whether it's a gene mutation, whether it's the COL1 gene or some of the other genes that cause it. It's very difficult for you to work out whether they'll pass it on or not. The ones that are inherited for parents, if you got the gene from your parent, because when you do gene testing for this child, you have to test the parents as well. The one that you got from your parents, you're more likely to pass on. If you're a mutant, less likely. That's the general genetic people way of thinking. But you'll have to ask a geneticist.
I think everything again boils down to the fact that we do not have a concerted effort that allows us to look after these children, because they're like children with malaria, sickle cell or something else. There's really no difference. It's just a child who has a challenge that can impact his life if he's managed a certain way or not managed, and a challenge he can overcome if he's looked after. We've kind of overrun our time. This is 4 minutes past. I wonder if there are any comments or if we can proceed to round up. No other questions, no other comments. We have Prof in the house, Professor Adigbende, and I was hoping that we could get his comments and his final comments in terms of all the things we've been talking about, in terms of the society and in terms of closing the meeting as well. I did send him a message. I don't know if he's seen that via chat. So, sir, if you don't mind, sir, could you please kindly unmute and kindly close the meeting for us?
Hello.
Hello, sir. Good evening, sir. You're very welcome, sir.
Good evening, Ma, and good evening to my boss, Dr. Adedapo, and the entire NOA. I want to appreciate the lecturers of today and the key important topics that have been discussed, and all the questions that have been raised and the way they have been analyzed. My little comment is that one, starting with the last presentation, that is the osteogenesis imperfecta. It's really commoner than we may be imagining. Depending on the area we are practicing, where there seems to be a kind of unsuspected consanguinity, or in communities where there is a kind of intra-community marriage setting. This osteogenesis imperfecta tends to be commoner in those communities. And it's unfortunate that many of the people that have been involved, majority of them couldn't afford even significant orthopedic care. Most of the time, the first set of presentation is coming to find out what is wrong with the child. And by the time you're asking them to go and do baseline investigations, it will take special social worker surveillance for them to be able to come back for 1 or 2 follow-up before they will disappear. And what happened to those children, especially those of us that practice in the rural areas and semi-urban, that may be the end of that child, which is a little bit different from what counterparts practicing in Europe, in North America, and other developed countries, where they tend to have good social network support for those children, and they are able to follow them up. Then the issue of a challenge for us as a Pediatric Orthopedic Society of Nigeria is this issue of genetic study. I think after this lecture, we want to communicate with Dr. Adedapo as regards this area so that we can leverage on his experience in UK. We don't mind a collaboration on some of these supposedly rare conditions, not only rare, but those conditions that we are limited in typing their genetic diagnosis. We want to work with him as a society, and I believe that the major Nigerian orthopedic centers, Igobi, Kano, Enugu, we can do a kind of regional study and be able now to type our own osteogenesis imperfecta. I think it's a worthwhile research that we can elaborate on for 1-2 years. At the end of the day, we can get sponsorship for the study, and that is one thing. As got the issue of surgery in terms of nail for them, well, it's obvious that we do not have the financial capability for now. Maybe as the Nigerian Orthopaedic Association is helping to push forward the issue of research institute with through the assembly, and we hope we'll be able to get to a point that we'll be able to incorporate this into this management of our cases in Nigeria. But as of today, I think those that can afford it, we should be able to link up with the centers that have the facilities and the skill to manage them. In the meantime, we can just improve on the diagnosis, at least to embark on the genetic study of our osteogenesis imperfecta cases. And I think this is the way to go. Now, as regards the issue of rickets, there is the pattern of rickets that we do have. We tend to have many cases with calcium deficiency rickets, which we need to look into. Professor Ogini, along with one researcher from JOS, did a lot of work on rickets and even the genetic aspect of rickets. And they find out that in this part of the world, in addition to the classical vitamin D deficiency rickets, we do have preponderant number of patients with calcium deficiency rickets. Then we tend to have neglected rickets. This is one thing that we have seen. And if you practice in the rural areas and the semi-urban, we tend to have many of these neglected rickets with very florid manifestations, florid clinical radiologic features of rickets. For the resident going for exams, I just want to let them know that when a child is having rickets, especially huge rickets, and is also having lung disease, we must also be on the lookout for concomitant exostosis, so that we are not carried away with the genoviral deformity, but try to look more, because when they ask a candidate to examine the knee or examine the limb of this child, please let us go ahead and ensure that we look for other features that the child may be having and that may also help us in the diagnosis. As regards the general workup and the surgical approach to this group of patients, well, in our own environment, in the olden days, I'm talking of 20, 30 years ago, many of our children, they are not obese. But today, set of children that we are having, I mean, pediatric cases, they are tending towards obesity. I have seen in Mayo Clinic a 4-year-old child weigh 48 kilograms. And here we have seen similar among the newly married or young couples having their children overfed. So as a result, we are likely going to have more of these cases. And the approach, many we are practicing now in the era of media and social media informations. We may need to do more of surgical interventions as time goes on because of this progressive increased obesity of those children and with underlying rickets, because these children, they are being taken to school. At the school that they are taken to, they are not exposed to vitamin D. And when they come back from school, they are also put in their 3-bedroom flats. They don't go out. So we may having a lot of insufficient vitamin D cases, like Dr. Ezag has said, that they are seeing a lot of them in Igbobi, and the same thing goes for many of the centers. So having said this, I just want to appreciate the presenters and our teachers for these wonderful topics. Thank you so much, sir.
Thank you very much, sir. Thank you for your kind contribution. I will await some emails from you on how we can move some of these issues forward, both the funding for these children, because I think if their treatment is funded, they won't run away, and also the research bits, which I'm particularly keen on. Thank you again, Prof.
Thank you very much, sir, for your kind comments and your insights. I suppose with this we can proceed to close the meeting, and we'll continue again next week with spine on Saturday and pediatric orthopedics on Sunday. We're gradually coming to the close of the spine and pediatric orthopedic sessions, and then we'll be moving into hips and knees and shoulders and so forth. So see you all next week, and do have a lovely week. Thank you.